Today, I'm going to present a topic on how monitor affects serum sodium levels. Salt is an important raw material for the processing, storage, and sorting of food, and it is one of the essential elements that plays an important role in the physiological function of the human body. However, in order to compensate for the increased mineral concentration of the blood, in the case of excessive intake of salt, the water in the kidneys is reabsorbed into the blood, and the amount of water discharged to the outside of the body decreases, resulting in increased blood flow in the body. First of all, let's talk about sodium ions for known hypertension. First, there is a correlation between the salt intake and the incidence of hypertension. People who do not exceed 25 milliequivalent per day of sodium ion intake do not increase blood pressure even when older, and there is no real hypertension. However, hypertension and stroke are very common in people with high salt intake. Second, low salt intake and sodium ion diuretics lower blood pressure in most hypertensive patients, and the effect of sodium diuretics is weakened as the salt intake increases. Third, when sodium ion is stored by mineralocorticoid administration, blood pressure rises, and restriction of sodium ion intake can prevent blood pressure rise. The sodium ion retention associated with hypertension requires chlorine ion as a negative anion. Therefore, sodium ions are stored with chlorine ions and stored together with sufficient water to maintain normal osmotic concentration. The result is an increase in plasma volume, which is actually the basis for this increase in blood pressure than sodium ion itself. For this reason, I would like to explain osmotic diuretics among the treatments for hypertension. An osmotic diuretic is a non-electrolytic substance that is filtered in the gut sphere but is not reabsorbed in the tubule. It is a substance exhibiting diuretic action by increasing the osmotic pressure of the urine and inhibiting the reabsorption of water in the tubule. Therefore, serum sodium levels and serum chlorine levels will increase when osmotic diuretics are used. To determine whether serum sodium and serum chlorine levels were elevated, we examined changes in serum electrolytes administered with mannitol. Mannitol was used to reduce intracranial pressure, so we administered the appropriate amount. The subjects were 10 male and female patients who had not received mannitol within 1 week and had no heart and kidney disease. After the onset of the operation, the skull was opened and then dosed with 0.6 to 0.9 gram per kilogram of body weight for 20% mannitol over 5 to 10 minutes. Before the administration of mannitol, Blood samples were drawn through a catheter inserted into the radial artery and used as a control for serum electrolytes. After 30 and 60 and 120 minutes of monitor administration, serum electrolytes were measured by the same method. Patients were between the ages of 18 and 65 with an average age of 44 years. The sex distribution was 5 persons and the average weight was 55 kilograms. Monitor was administered at a rate of 0.7 gram per kilogram over 10 minutes, and furosemide was instilled 0.1 milligram per kilogram 5 minutes after administration of mannitol. As shown in the table, serum sodium and chlorine levels were significantly decreased 30 minutes after administration of mannitol, but the measured values at 1 hour and 2 hours after administration were not significantly different from those of the control group. There is also a graph. The reason why the serum sodium level and serum chlorine level decrease after 30 minutes seems to be because ascending loop of Henle suppresses reabsorption of sodium, potassium, and chlorine, so that a large amount of water and electrolytes are discharged into the urine through the collecting tube. However, as the serum sodium level increases over time, it may be due to less reabsorption of water or higher electrolyte uptake in the ascending loop of Henle. Thank you for listening to my presentation.